Hello, you're listening to Genomic Matters. Genomics has and will continue to revolutionise how we understand and treat cancer, with the potential to significantly improve patient outcomes. Genomic sequencing has become an integral part of precision medicine, enabling oncologists to tailor treatment plans based on a patient's unique genetic makeup. In this podcast, Dr. Matt Krebs meets with Grace Berry, Charlotte Knowles and Professor Jim Hill to discuss genomics and its role in detection, diagnosis, treatment and identifying cancer risk.
So, hi, I'm Matt Krebs. I'm a clinical senior lecturer in experimental cancer medicine and an honorary consultant in medical oncology at the Christie Hospital in Manchester. And I'm also the clinical lead for cancer genomics at the Northwest GLH. All sounds like a mouthful, but essentially I work in drug development for cancer and do a lot of genomics work in relation to that. Thank you to everyone for joining us today to discuss genomics and how that can be used to enhance care for cancer patients. Delighted to be joined by a team of people here, and I'd like everyone just to introduce themselves if that's okay. So if we go around Grace, Charlotte and Jim respectively, perhaps if you could just briefly introduce yourselves.
Yep. Hi everyone, I'm Grace Berry. I'm a project manager at Cheshire and Merseyside Cancer Alliance, and I'm working specifically within the personalised care and the genomics work streams.
Okay, thanks. Charlotte.
Hi, I'm Charlotte Knowles and I work at East Lancashire Hospital Trust as a breast care nurse. Most of my role is in the family history clinics, and that's how it ties in with the genetics and genomics.
Okay, great, thank you. And Jim.
Hi, thank you. Good afternoon. So I'm Jim Hill. I am currently the Deputy Medical Director of the Northwest Genomic Medicine Service Alliance. And prior to that, I was a consultant in colorectal surgery, mainly colorectal cancer in Manchester, with a long-standing interest in the patients with a familial history of colorectal cancer.
Fantastic. So really, thanks very much for joining us this afternoon. Looking forward to this discussion. So genomics really has revolutionised cancer care over the last 10 to 20 years. We've come a very long way in how we use genomics. And essentially what we're doing is looking at the genetic makeup of an individual's patient's cancer to try and understand more about them as an individual cancer, rather than assuming that all cancer types are the same. So it gives us a lot of additional information. Grace, perhaps I can just bring you in first of all. We hear terms such as precision medicine, personalized care, targeted therapies, tailored therapies. Perhaps you can just try and summarize all that for us as to what all that means.
Yeah, no problem. I mean, first of all, I think a one-size-fits-all healthcare system approach, simply cannot meet the increasing complexity of people's needs and expectations. So personalised care and medicine uses, new approaches to better manage patients' health and targeted therapies to achieve best outcomes in the management of disease and the predisposition to disease. So targeted therapies are designed to attack specific molecular targets. They avoid healthy cells and therefore reduce the side effects of treatment compared to the traditional chemotherapies. I'm sure one of our clinical colleagues here will be able to give us an example of that shortly, so I'll hand over to them in a minute. But with the help of genomics, I think a patient's treatment plan, as you say, can be tailored specifically to them, because genomics can predict how a person will respond to certain treatments, which then enables oncologists to choose the most suitable therapy for that patient while avoiding ineffective treatments and reducing unnecessary side effects. So, the evolution then, or the progression of the cancer over time, can also be monitored through genomic analysis. And that's really important when patients go on to develop resistance to certain treatments. So monitoring those patients over time, can allow for treatments to be adapted or new treatments to be adopted so that improved outcomes can be achieved as well. So I think genomics has also really accelerated the development of new cancer treatments and identifying potential drug targets and selecting patients for clinical trials based on their genomic profiles. So that obviously then allows for more efficient, effective clinical trials, which has a knock-on effect leading to faster drug approvals, better treatment options for patients ultimately, and monitoring through liquid biopsies as well.
Great, that's great. Thank you. That's really explained that nicely. And yeah, I mean, perhaps just to bring that alive with some examples. So some things that spring immediately to my mind, HER2 in breast cancer and use of HER2-directed therapies like Herceptin is a targeted treatment based on sort of genomic testing. EGFR in lung cancer, perhaps a poster boy for genomics. About 10 to 15% of lung cancer patients have an EGFR mutation and they respond to EGFR inhibitors. So a tablet form of therapy really well. And there are lots of other examples as well in melanoma, in colorectal cancer, in all sorts of cancer types now. And even some genomic targets that go across all cancer types, like NTRK is perhaps one of the most recent ones that can occur in any disease type or any cancer type, albeit it's low frequency. And there are NTRK inhibitors now available in the clinic that can work very effectively. So it really has changed things. And you're right, it's taken us away from that one size fits all of giving everyone chemotherapy to being able to select these targeted treatments. You mentioned about the liquid biopsy. Perhaps I can just touch on that to expand on that a bit further. So we historically, the gold standard way we look at genomic testing of a patient's cancer is from a biopsy sample or a surgical sample, and that goes to the lab and they extract the DNA and we can do the genomic tests on that. But for some patients, it can be quite difficult to obtain a good sample from a biopsy, either because it's hard to get to or the needle biopsy that's taken has got really very small amount of DNA in it and there's not enough there for the genomic tests. And sometimes if the genomic test fails, we have to go back and do further biopsies for patients, which can delay time to treatment and be uncomfortable for patients. So a new approach to genomic testing is through so-called liquid biopsy, which can be done through a simple blood sample. So we know that for some cancer types, they can essentially shed DNA into the bloodstream. And the technologies now are such that from a simple blood test, you can extract that DNA that's come from the cancer and do the genomic tests on that and get the same information as you would from a biopsy sample. Now, it doesn't work for absolutely everybody, but it really is a very exciting way of doing genomic testing that's much more patient friendly. And to your point about monitoring patients as well, because we know that cancers can change over time, it's much easier to get repeated blood samples to retest for genomics than it is to do repeated biopsies on patients. So really helpful approach. And there's a couple of things just to call out in relation to that as to what's going on at the moment to help develop this. One is something called the Target National Study that I run across as a study that's run across the UK for patients who've exhausted other treatment options and want to look for clinical trials. We can, assuming people meet certain criteria and a certain level of fitness and will be eligible for trials, we can do a blood test on them. We look for several hundred genes from that blood test, and the result comes back within a couple of weeks. And we discuss those results through a specialist, what we call a molecular tumor board, and we can then try and match patients to clinical trials based on any gene abnormalities that we might find. And that's been a really promising approach, and is enabling more patients to get onto clinical trials of new drugs. The other thing that's worth mentioning in the liquid biopsy space is NHS England currently have a very exciting pilot going on for patients with lung cancer. So in order to try and speed up the diagnosis and all the tests that are required for lung cancer patients, essentially, if people have a possible lung cancer identified on a CT scan, at the moment there's a pilot going on that a blood test can be taken from those patients. It gets analysed for all the genomic tests like we've discussed, and the result can come back in a couple of weeks and can enable patients to get on to targeted therapies if they've got a genetic mutation there. And it really speeds up the process. compared with doing a biopsy, and sometimes if those biopsy samples failed, like we discussed before. So something really to keep an eye on, and NHS England really wanting to drive forward use of liquid biopsy in the clinic as well. We just need to collect a bit more data to show its value. So what's this space for liquid biopsy? Let's have a slight change of tack here. One of the other aspects of genomics is about cancer risk. Genomics can be used in different ways. Charlotte, perhaps I can bring you in here as a breast cancer nurse. What's your experiences been of genomics within cancer care for your patients?
For my patients, I feel it fits every part of their cancer journey now. Whereas my background was chemotherapy, so as you've said, HER2, 10 years ago when I started was the only thing, but now I think it comes across from preventing their diagnosis, from their screening to diagnosis and their treatment. So I think it has a part to play in every part of their cancer journey as well, or even for the family history patients that don't have a cancer yet, trying to work out their kind of genetic risk for developing a cancer. And their percentage of developing some kind of mutation to be able to increase their screening regime, to be able to refer them on to get that genetic test. Just in the time that I've been genetic testing our breast cancer ladies, for the past 12 months, the profile for the actual genes that we're tested has got wider as well. So again, that's detecting more genes that we're able to look at as well. And then not only that, when people are the breast cancer patients that we test, it's looking at them. Normally, it used to be a very surgical discussion and things like that, but now we've got the PARP inhibitors, so it's coming into the oncology field. So it does really cross all parts of a patient's diagnosis, from, like say, not even being a patient working out their risk to kind of looking at an oncology treatment after their surgery, radio, chemotherapy as well. So it comes in all parts as well. So I don't think you can really avoid genomics in any cancer field. It's there and it plays part in every part of that journey as well.
So one of the most common genes I think people will be familiar with for breast cancer is BRCA. So perhaps just expand on that a little bit, Charlotte. How does that work for BRCA testing? What sort of patients would get tested? What does it mean? What would you do when you get a positive result back?
So we test primarily our breast cancer ladies. We'll sit down with them, take a family history and talk through that family history, why it's important that we're taking that. And it also can mean for our ladies, especially if they do come back with a BRCA1, BRCA2, we then start the conversations of, yes, you've had surgery for the cancer, but then it's explaining to those ladies about their risk. So it's saying, as much as you have a gene, that your risk isn't kind of over because you've already had that cancer. It's this risk is ongoing. What can we do to help? So referring them on and discussing about the risk reducing surgery and the impact of other cancers as well. So the ovarian, we touch on that as well with them as part of that conversation. And then also with the BRCA1, BRCA2, we've just had the new PARP inhibitors. So that's playing a big game changer for our breast cancer ladies if they are coming back as a BRCA carrier as well, giving them that more additional medication. Especially when I'm having a conversation about genetic testing with our breast cancer ladies, I'm always mindful saying that it's not taking away anything from your treatment. If anything, it's adding more treatments to you and helping with your individual prognosis. As we've said, it's not a one size fits all. This is based on you indefinitely and your genes.
Yeah, and you mentioned the PARP inhibitors, and as you say, I think they've been recently approved for patients who've got BRCA mutations. We know that PARP inhibitors can be really, really effective for those patients. So it's another example of actually the genomics here, not just telling us about inherited risk of cancer, an impact of other risk of cancers that patient might have, but also in selecting an optimal treatment as well. So it's kind of a double whammy, right, for BRCA there.
Yes, definitely. And as Grace said, these treatments are standardly better, well tolerated than your standard chemotherapies as well. So again, that's another improvement that yes, there's a treatment, but they're actually better tolerated than a standard chemotherapy as such as well.
Yeah, and there's the risk for those individuals' children as well, right? How does that factor into things?
For children, did you say? Sorry.
Yeah, so for in terms of the inherited risk, if a lady's diagnosed with a BRCA-positive breast cancer, you'd refer them to the clinical genetics, and presumably that would inform about risk for their family as well.
Yeah, so when we get any positive result, we refer into Manchester. As part of that consultation beforehand, we've had that chat regarding how it can impact your family. Some clinicians kind of have always had that old school view as, oh, it's just a blood test. So when they come for me, I always ask them why they're here today, and they say, oh, it's just a blood test for my children. And I always go, yes, it is. It impacts your children, but let's go through the bigger picture as well of how and why as well, and really break down that more education about genes, really, to show them why it is so important that we need to do this test as well.
Yeah.
And then they are then referred over. For the family history patients, we don't do their genetic testing. They are automatically sent over to Manchester Regional Genetics Centre for that testing and those conversations.
Yep. Okay, thanks. That's really interesting. So, Jim, perhaps I can bring you in here. So Charlotte's spoken about testing and treatment in relation to breast cancer, but what part does genomics play in identification of risk, early detection, diagnosis for other cancers?
Thanks, Matt. As I mentioned, most of my background relates to colorectal cancer. And a bit like the BRCA genes, there's an inherited condition which predisposes patients to colorectal cancer called Lynch syndrome. And if someone has Lynch syndrome, then there's a 1 in 2 chance of them passing that on to their children, and a 1 in 2 chance that their siblings will also carry that mutation, that abnormality in a gene, which increases your lifetime risk of developing colorectal and endometrial cancer. So over the last couple of years, we've been introducing, and this is actually a pan-England strategy of testing every cancer that's either colorectal or endometrial for the markers, the genetic markers, which would identify someone as having Lynch syndrome. There are very considerable advantages to that. To the patient, they can have targeted screening. Patients with who are identified as Lynch syndrome can be eligible for some slightly different treatments. And if it's identified, then at-risk family members can also be tested to see if they have Lynch syndrome, and they can be entered into screening programs. And if you're in a screening program, this reduces your risk of developing colorectal cancer. And if you do still develop the cancer, it is nearly always identified at an earlier and more treatable stage. So identifying at risk in individuals does allow them to really be better managed and reduce their chances of developing cancer, and improve the treatment of their cancer. I think as well as Lynch syndrome, it's now pretty much standard practice for anyone having chemotherapy for colorectal cancer that they will have a mutation analysis of the cancer, and that will influence the oncologist in regard to the decisions that they make about which chemotherapy drugs to give. And this both increases the likelihood of the chemotherapy drug being effective, but also enables the clinician to avoid drugs which are less likely to be beneficial, and therefore reduces the risk of side effects from that chemotherapy treatment. I think, around 30 years ago, Matt, there was the concept, I'm sure, remember, of the magic bullet to treat cancer. And I think that was clearly a naive idea that we were going to identify one thing that would cure all cancers. But I don't think it's too far-fetched to say that the development of genomics has allowed us to identify literally hundreds now of what are effectively magic bullets, which will treat specific cancer targets and are resulting in much more effective cancer therapy, and indeed reduced side effects. And a further example of that you mentioned is with immunotherapy for some patients with colorectal and endometrial cancer. So if you have what's called a mismatch repair deficient cancer, it gives you a particular biology where the body's own immune cells, white blood cells, are able to identify the cancer cells as foreign cells. And there's a treatment called immune checkpoint inhibition, which allows those immune cells, allows those white blood cells to kill the abnormal cancer cells. And indeed, that's having some really dramatic effects on the mismatch repair colorectal cancers, more dramatic effects than I think I could have ever believed, having observed the effects of treatments on colorectal cancer. So there's, as Charlotte said, with breast cancer, I think genomics really is playing a role right through the treatment process, diagnosis, and treatment of many patients with colorectal cancer, and has undoubtedly improved our range of treatments and the efficacy of the treatments that we can offer to patients. And just finally, with every colorectal and endometrial cancer being tested for the condition of Lynch syndrome, it really helps us to manage some of the issues with regard to equity of access for cancer treatments and genomic diagnosis.
Thanks, Jim. I think you've articulated all that really beautifully. I'll come back to that point in a second around equity of access. I think that's a really important point. I just wanted to sort of flag, we've really discussed here only a few examples, but some really, really strong examples of how genomics is being used in the clinic and really changing the paradigm of how we manage cancer patients and the importance of it. There are, I don't know exactly how many there are, but there are multiple targeted treatments available, Jim, as you're alluding to, right, across multiple different cancer types, if you've got certain genetic abnormalities in your cancer. And just, from my perspective, working in drug development and seeing the next generation of drugs that are going to come along in the coming years, there's a whole raft of them in early stage clinical trials of new targets as well that equally look really, really promising. So they're continuing to come about. So really has, had a dramatic impact. Hopefully people are aware of people who are listening, the Genomics Test Directory. So this is something that's been produced by NHS England through the Genomics Medicine Service, which essentially is a menu of genomic tests that can be offered to cancer patients. There's one for cancer patients and one for rare diseases, but we're focusing on cancer today. Really, we should be offering all these genomic tests to all our patients with newly diagnosed cancers, so that we can select the best treatments as we've discussed today. So I think that does bring along an important point, and I think you've all probably got some experience of this, of how we implement all these tests and make sure that people are getting access to this. So my final question to you all is how overall can we increase awareness of genomic testing, both across all aspects of medical professionals and also for patients and public? How do we increase the uptake of testing, and in particularly in those minority groups as well, to ensure that we have equity of access? And I'm perhaps just going to come to you all just for your thoughts on this. So Grace, can I come to you first? What are your thoughts around that?
Yeah, I think there's a big education piece to be done, both across trusts nationally, but also with patients as well, and making sure the kind of genomic wording of things gets across to patients. When we worked on the 100,000 Genome Project, I think that was quite a big learning point of how to get informed consent from patients, not overwhelm them with too much of the science and the detail, but increase their awareness overall, I think, of genomics and that it exists. And I suppose podcasts like this and, the awareness of the Genomic Medicine Service Alliance and that that all works to take some steps towards that. But I think, we've all heard of the postcode lottery, haven't we? Ensuring equitable access to genomic testing and targeted therapies is definitely an ongoing challenge. At the Cancer Alliance, we have a health inequalities and patient engagement team who are doing fantastic work to tackle some of the inequalities, linking in with communities, trying to really understand what the barriers are to accessing the healthcare that patients need, and working, to support improvements for patients. I think it's absolutely vital to address the disparities in healthcare and variation in access to genetic testing, to ensure that all patients, regardless of their socio-economic background, have access to the same cutting-edge treatments, really.
Yeah, absolutely. And Jim, you've got first-hand experience of this yourself in implementing the Lynch testing. What's been your experience of it?
So I think one of the advantages of the Lynch testing is the fact that everyone's being treated, and I think that we are moving towards more universal use of genomic testing, mutation testing within multidisciplinary teams. I think, as Grace says, there is still, even though clinicians are often dealing with only one or a relatively small range of cancers, certainly I think the surgeons do need ongoing education about the importance of genomics and how to use them. The fact that clinicians no one has to worry about paying for the genomic tests is helpful, because the GLH will do them without charging trusts. I think that helps, but there are still ongoing issues with some minority ethnic groups, particularly I think with regard to early presentation with cancer symptoms, and for uptake of cancer screening. Certainly within the Northwest GMSA, equity of access is an important part of our role, and we are trying to run genomic cafes across the Northwest. We have people who are actually going into the ethnic community meetings, and to try to address those communities directly. And there is someone called Naz Khan who's working in East Lancs, who's trying to do work with some of the minority ethnic groups in that part of the world. So it's fair to say it's an ongoing challenge, Matt, but I think there are specific initiatives in place which will hopefully improve that. And then I think as individuals and communities see the benefits of attending for these things, hopefully that word of mouth will lead to a general improvement in presentation and uptake of screening.
Yeah, absolutely. It sounds like there's some really great things going on to try and encourage this testing. So yeah, really fantastic things happening. Charlotte, but what are your views and your experience in breast cancer and uptake of testing?
Yeah, just building on what Jim says, I think with our breast cancer ladies, we're testing the people that have already got a cancer. So we've got them from all walks of life, whereas in family history, you see a lot of people coming to the family history clinic because they've got a relative that's been diagnosed. But it'd be good to get a wider aspects of people coming through the clinic, that they're not only coming because they've just had a relative diagnosed, that it's something that people are more aware of, rather than they've just had a relative diagnosed. And I know in East Lancashire, they in our trust, the Macmillan coordinators go into the mosques with the screening, the bowel screening and the breast screening, and we're hopefully going to try and tap into that to make it as part of this general screening, more awareness, to see that it's something that they can access regardless if they've not just had a family member diagnosed and that's what brought it to their mind, but as something that, well, what can I be tested, or if that makes sense. And then with our breast cancer ladies as well, sometimes it can be difficult being receptive to that, just because they're eligible for a test. they've obviously got to want to have it as well. So again, I think there's some more work that needs to be done on that. And as Jim said, not only with surgeons, but I think a lot of healthcare professionals, because a lot of them see genetics and are a bit worried and think, oh, it's nothing to do with me, so shy away from it. But if we can get even just more of the clinic nurses just to have it on their radar and start those discussions with patients, so it's not as scary to patients when you start saying about genetics and genomic testing. More health professionals that know about it, we can get the more education out there as well to the patients as well.
Yeah, and I think actually there has been a significant increase in awareness over the last 1 to 2 years. I think there's still a long way to go, as we've discussed, but we have come a long way. And perhaps just a couple of comments from my side as well. I mean, from the GL8, the Genomics Laboratory Hub perspective, the GL8, we're really trying hard, along with Jim and GMSA colleagues, to get these tests implemented routinely. So at the point of diagnosis, it should almost be reflex testing for many indications to make sure these genomic tests are just done as part of the diagnostic pathway, and therefore you do help with the equity in that way, because it's all patients that are being diagnosed. That doesn't apply for all genomic tests. There are some that are done later in the pathway, or there are some that may require a consent discussion, I guess, like BRCA, Charlotte, right, for your breast cancer patient. So it doesn't work for everything, but it's just one of the ways we're trying to get more access to the testing. And the other aspect to speak from my perspective in drug development is patients being referred for clinical trials as well, because there is definitely discrepancies in terms of the sorts of patients that are being referred to us for studies. Not everyone is getting equitable access to that, and I think it's really important that we're raising awareness of clinical trials being available for patients, for all patients. So if they've got genomic abnormalities, we can offer those opportunities. So again, something we're working on from the research perspective as well, the trial perspective, to try and get more patients referred through. I think this has been a really, really great discussion. Thank you hugely to Grace, Charlotte, and Jim for joining me for this podcast discussion. I've really enjoyed this brief time together and learning about what you're all doing and what's happening in the northwest region. If any of our listeners would like to hear more about what's going on within the Alliance, or our projects or education and training available, would perhaps refer you initially to our website, and there's contact details on there as well. So thanks all for joining. Bye for now.
Thank you.
Thanks.
Bye. Bye.